Hey, what's up guys? I'm Augie, along with my group Camille, Andrea, and Liliana. Today we're going to show you the projections for the thoracic spine. Pathology is going to be kyphosis, subluxation, fractures, and zygapophyseal joints with the oblique positions. Let's get it. So I'm going to be demonstrating the APT spine. So first you're going to get the room ready, and it's going to consist of having a 40-inch SID, and then you're going to check to see it's going to be a 14 by 17 IR, and it's going to be in portrait mode. You're going to check to see if it's aligned, which it is. And after this point, you'd go get your patient, but for now we only have Molly, so you'd position them. You'd have them laying straight on their back, and you would put a cushion underneath their legs or knees to lessen the curvature of the spine. You'd have their arms straight to their sides. And to get the CR lined up, you go CR on the mid-sagittal plane, and you're going to position it 3 to 4 inches below the jugular notch. So you're going to go down 3 to 4 inches. And this is just going to be performed like a AP chest. So you're going to have a little bit of lights on top of the shoulders, and then you're just going to collimate inwards because you don't need all this excess room. And then of course you'd also shield the patient, and at this point you'd use when you get the computer ready, you do a 75 to 85 kV range, and you expose on expiration, so you tell them to breathe in, breathe out, hold it, expose. Another thing to know is do not make the same mistake I did. You also have to put a marker on. So this is the right side of the patient, so we're going to put a right marker in here. And make sure you don't get it in the anatomy, just in the light field right there. And then you would go ahead, tell the patient to take a deep breath in, breathe out, hold it, and then get the x-ray image.
My name's Camille Hernandez, and I'm going to be showing you how to do the right and left posterior obliques of the T-spine. Some of the pathological indications include pathology of the zygapophyseal joints and of the T-spine. Both right and left obliques are taken for comparison. So to start, we're going to position our tube at 40 inches from the table. And for our Bucky, since it's digital, it's already at a 14 by 17. And it's already aligned. Now to position the patient, we're going to use an angulator, and it's going to be 20 degrees from true lateral, which is 90 degrees. I'm also going to use a sponge to hold her in place. I'm going to bring Molly's hands forward into a praying position, so where they're up near her head. And I'm going to use a weight to hold them in place. I'm going to flex her knees. Make sure the sponge is under there. And our CR is going to be 4 inches below the jugular notch at T7. So I'm going to measure 1, 2, 3, 4. I'm slightly above, so I'm just going to move her down just a little. We're going to use a shield to shield any tissue that does not need to be exposed. We're also going to place our marker. The left marker, so she's laying on her left side. Put it in the upper corner. And our KDP for this position is 90 to 95. We're using center AEC chamber, and at this point we would expose.
Hi guys, so my name is Liliana Juarez. I'm taking over Camille's exam. So now after the posterior obliques, we're just going to roll her back into a true lateral for the lateral T-spine. The lateral T-spine is to show any thoracic spine pathology such as compression fractures, kyphosis, or subluxation. So you just roll her back into the lateral. On Molly, we use a weight just to try to maintain her position. On a patient, they can help you out for the most part. Just make sure she's there. Your centering is going to be 3 to 4 inches below the jugular notch, so just make sure that that CR has been maintained throughout your rotation. I just need to come up a little bit. Okay, you want to make sure that you have your MSP aligned. Make sure that her shoulders aren't too rotated or under-rotated. So she's looking good there. Keep her arms like that. Then you want to keep your SID at 40, as we did for the other projection. Your KVP is going to be the same, 90 to 95, depending on your patient. Swapping out Camille's left, I'm going to put mine. Make sure that it's still aligned. Moved a little, so we'll just adjust it. And for this, we have a breathing technique, the orthostatic breathing technique. So you do a 2 to 3 second long hold, and you just have them breathe in and out throughout it. That way you can blur out the lung markings and the rib markings. Before we begin the exposure, we're just going to slide under a sponge to help support the patient's waist while also providing uniform density across the image. Following up with that, we're going to check our collimation, collimate down, tighten it up a little bit. Along with that, we use a lead backing just to help pick up some of the scatter that's going to come through. And then shield your patient. At this point, I'm going to instruct them that we're using the orthostatic breathing technique. So we're going to do a low MA, hold it for 2 to 3 seconds on the exposure, and they're just going to breathe in and out to help blur that out. So we practice it once with them. I'm going to step away, breathe them, and then expose.
Hi, my name's Andrea Lindquist, and I'm going to be taking over from Liliana's spot. Since our patient is already in a lateral position, I'm going to be demonstrating the cervical thoracic lateral, more commonly known as the swimmer's projection. This is used when C5 to T3 is the area of interest. So my patient is already in a lateral position. I just want to make sure that they didn't shift. Make sure she's nice and true lateral, 90 degrees. I'm going to leave her arm that's closest to the table in the praying position. The other arm, I'm going to grab it and bring it slightly backwards. With a real patient, to make them comfortable, you can bend their elbow and have them put it like this, but Molly's kind of stiff. So we'll leave her arm back. You want to leave the mat to clean up the scatter. You want to leave the shield to make sure to protect your patient. And my CR is going to be at T1. And for the swimmers, you just kind of want to skim the shoulder right here. So the CR is at T1, which is 1 inch above the jugular notch. But like I said, if you just kind of make sure that you skim the shoulder, you need to move up just a little bit. You skim the shoulder right here. You also want to check that you're aligned to the patient's spine. Sometimes turning this which is kind of stiff. If you turn it, it goes it follows the natural curve of your patient, so you can't turn your tube head. And don't forget to collimate. Okay. So that's good. Our technical factors, you're still going to use a 40-inch SID. Now for swimmers, the erect position, which is 60 to 72, is preferred. However, we're using Molly and we're doing it tabletop, so 40 inches. And you can do that with your patient if they can't stand. So check to make sure that you have your 40 inches. If you're using the cassettes, you're going to use a 10 by 12 cassette because it's a smaller area that you're concentrating on. However, all of our digital detectors are the 14 by 17, but just make sure you collimate. And your marker, I like to place mine in the light field so that I know that it's good. The last thing you're going to do is explain the breathing instructions to your patient. And for the swimmers, you want to do take the exposure on full expiration. So you're going to ask them to take a deep breath in, let it all out, and take the exposure then. And that pretty much covers the swimmer's position.
So continuing off of what Drea did, we've already got the patient in a lateral position on the left side. Now we're going to get her into a position on the right side to do her entry. I'm going to remove the weight. Remove the sponge and the extra leg. And we're going to roll it back. Move this out of the way. We're going to move the center of the table. I'm going to use my angulator again to get her a 20-degree angle from 90 or from true lateral. I'm going to use a sponge back here to prop her up. About a 20-degree angle right there. I'm going to bring Molly's arms up into the praying position again. And I'm going to use a weight to hold her down. Make sure her body is perfectly straight with the table. She's going to flex her knees again. And we're going to center the same way as before at T7. So we're going to go about 4 inches down from the regular notch. 2, 3, 4. Instead of moving the tube, I'm just going to move the table. So about right there. I'm going to move that just a little to get it aligned. And now I'm going to straighten out or align my straight with my center. I'm going to put my right marker on the right side. And we're going to collimate to just below the end of her ribs. Making sure we get all of T-spine. Making sure we have enough light to get the vertebrae. We're going to shield any tissue that doesn't need to be exposed. The KDP is still the same, 90 to 95, and we're going to expose on full expiration.
Clinical indications for the APT spine include pathologies such as compression fractures, subluxation, kyphosis, and scoliosis. With these images right here with the AP and lateral, you can see the T7 body. It looks like it's been crushed down a little bit, like a soda can. And with the lateral image, you can definitely tell that it's been compressed, and this pathology is what is known as a compression fracture. With this image, the pathology that's being demonstrated is scoliosis, which is a lateral curvature of the spine. So you can see around T2, T3 that the spine starts curving and doesn't come back until around L4. In this particular image, it's being done in a PA, but it can be done PA or AP, it doesn't really matter. So in this last image, this is just a basic AP projection showing the anatomy that's supposed to be demonstrated. So we have thoracic vertebral bodies, intervertebral joints, spinous and transverse processes, posterior ribs, and costovertebral articulations.
This is the RAO position. Some of the clinical indications involve the zygapophyseal joints of the thoracic spine. Both right and left obliques are taken for comparison. The anatomy demonstrated are the zygapophyseal joints. On an RPO position, the joints of the upside are what is demonstrated, and on an anterior position, the joints of the downside are demonstrated. Radiographs may be taken as a posterior or anterior oblique, but anterior is preferred to reduce dose to breast tissue and thyroid. These two images are of an RAO position and an AP position. In the RAO position, the zygapophyseal joints of the side of interest should be opened. However, the amount of kyphosis will determine how many zygapophyseal joints will clearly be seen. On the oblique position, demonstrated is the vertebral body, intervertebral disc space, and you can see the ribs as well.
Anatomy demonstrated in the lateral position for the thoracic spine will be thoracic vertebral bodies, intervertebral joint spaces, and intervertebral foramina. T1 to T3 will not be well visualized, but that's why we do a swimmer's position so we can get the extra vertebrae. The position should demonstrate open intervertebral disc spaces, and no rotation is indicated by superimposition of posterior aspects of vertebral bodies. Because of greater OID on one side, the posterior ribs will not be directly superimposed, especially if the patient has a wide thorax. No rotation is indicated by less than ½ an inch of space between posterior ribs. Significant amounts of secondary and scatter radiation are generated, so close collimation and placement of a lead mat posterior to the part are essential in maintaining image quality, especially in digital imaging. The optimal amount of support under the waist will cause lower vertebrae to be the same distance from tabletop as the upper vertebrae. A patient with wide hips will require substantially more support under the waist to prevent sag, or a patient with broad shoulders may require a 10 to 15 cephalic CR angle if the waist is not supported with some sort of sponge. In this image shown of a lateral T-spine, you can see the intervertebral joints, the thoracic vertebral bodies, and the intervertebral foramina of the right and left side.
The anatomy demonstrated for the cervicothoracic lateral position will be vertebral bodies and intervertebral disc spaces of C5 to T3. The humeral head and arm furthest from the IR are magnified and appear inferior to T4 or T5. In this position, you should see minimal vertebral rotation, and that will be indicated by superimposition of the cervical zygapophyseal joints and articular pillars and posterior ribs. The humeral heads should be separated vertically. Now, if your patient is not able to separate their shoulders, you can do a slight caudate angulation of 3 to 5 degrees. This next radiograph of a swimmer's lateral really demonstrates how the humeral heads separate in order to clearly visualize the region of C5 to T3. This concludes our presentation of positioning for the T-spine and radiographic criteria for the AP T-spine, the right and left, posterior, oblique T-spine, the lateral T-spine, and the cervicothoracic, or better known as swimmer's T-spine. Thank you.